sweet. I'm going to ask you to stand behind this blue line.
You could raise your right hand for me, please. Do you solemnly swear the testimony you're about to give in the cause now in hearing shall be the truth, the whole truth, and nothing but the truth so help you God? Yes. Thank you. You may be seated.
Going to make yourself comfortable in that chair.
Good afternoon, ma'am. In a nice loud voice, could you introduce yourself to the jury and spell your last name?
Hi, I'm Naomi Shin, last name S-H-I-N.
And ma'am, what do you do for work?
I'm a nephrologist, a kidney doctor at Mount Auburn Hospital and actually Cambridge Health Alliance Hospital too.
All right. And could you tell the jury a little bit about your educational training and background, please?
Oh, certainly. So after finishing medical school at UMass, I went to residency at Mount Auburn Hospital and then further trained in nephrology specifically for about 5 years at Yale University in Connecticut. And then I came back to be an attending physician in nephrology at both, like I said, Mount Auburn and Cambridge Health Alliance hospitals.
Okay. And so obviously a nephrologist is what sort of doctor?
A kidney doctor.
Okay. What is it? Well, let me start over again. What is it that nephrologists, kidney doctors do, sort of aside from the obvious, which is, treat kidneys, but what is it that you all do as a specialty?
Sure. When patients come into the hospital, we treat acute injuries to the kidney from whatever etiology or cause. So whether it's from low blood pressure, which is a very common cause of kidney injury, to hereditary causes, to patients who need dialysis, which is a machine that does the job of the kidneys. It takes your blood, it cleans it up, and then it gives it back to you. So the kidneys do a lot. They clear your blood of toxins. They make sure that you're not volume overloaded. In other words, what you put into your body needs to come out. Otherwise, we'd all balloon up. The kidneys help with that. Blood pressure. Electrolytes management. So any of those arenas that patients have trouble with in the hospital, I help take care of if requested as a consultant.
Okay. So you kind of anticipated my next question about what is it that the kidney does for the body, and it sort of functions as to process a lot of the waste in the body. Is that one thing?
Definitely. So the kidneys do a lot. They take your blood, they filter it, they get rid of all the waste products that we generate normally ourselves, right? Just by living, we generate waste products, and it gets rid of that through the urine. We eat and drink what we drink. We don't want to balloon up. We need to get rid of that fluid if we're not using it for whatever reason, right? Exercising, we need a little bit of extra hydration, etc. The kidneys know and figure out how much fluid you need to keep or lose. Blood pressure management is really important. The kidneys have sensors, and they can figure out if your blood pressure is low or high and respond accordingly. Electrolytes is a big thing, sodium, potassium. Again, things that you generally consume. The kidneys will be able to figure out and get rid of anything that you don't need. And then extraneous waste, so things that normally aren't in the body, medications, breakdown products, the kidneys know to kind of get rid of that in the urine.
All right. And so you were saying essentially that the kidney can be injured in lots of different ways. Is that right? Exactly.
Anything from straightforward trauma, right? Blood loss is but the most common though. So the kidneys are very sensitive to blood flow. They demand a certain amount of it. So if you have low blood pressure, the kidneys don't like that and they will be injured. And the cells within the kidney will start to die. Sorry, what was the original question?
No, that was the question.
Okay.
Now, ma'am, I want to ask you some specific questions about a specific patient that you assisted with by the name of Leroy Fowler back on November 12th of 2022. Do you remember that particular case?
I do.
Okay. And in preparation for your testimony today, have you had the opportunity to look over the medical records from Mount Auburn associated with Mr. Fowler's care at Mount Auburn Hospital?
Yes, I did.
Did you also have the opportunity to look at the medical records from Anna Jacques Hospital, where he was before he came to Mount Auburn for that particular illness?
Yes.
Had you, the Anna Jacques Hospital records, had you seen or were you familiar with the information contained in those at the time you were actually treating Mr. Fowler on November 12, 2022?
I did have most of the critical pieces of information from Anna Jacques because we have access to some of the notes that the physicians write, and that's in our system. So I read all of those notes.
Okay. So when was it that you first became involved in the treatment of Mr. Fowler?
So on the morning of November 12th, which was a Saturday, I was paged pretty early from our intensive care unit at Mount Auburn Hospital. And they were concerned about, his kidney injury. He clearly had it per his blood tests. But then a slew of other findings made them very concerned that the kidney injury was preventing him from getting better. So when I was paged and I spoke to the ICU resident, I believe it was a he, but he was concerned that there might have been some sort of ingestion involved because of the abnormal lab results, the metabolic acidosis, the osmolar gap, which I could talk more about in a second. But when that kind of information comes to me, they're red flags because the combination of kidney injury with severe acidosis with an osmolar gap makes me think of very few things. Each individually could be any number of things can cause any of those individual pieces, but together that heightened my sense of urgency. And so then I went to see the patient. He was already intubated, sedated, so I couldn't really examine him. He wasn't able to talk to me, but I collected a urine sample and I brought that back to my office and I spun it in my lab. Spinning is a very common technique that we are supposed to do to look at the urine to see if there are any diagnostic clues about what's going on in the kidney, right? So the kidneys filter blood, they make urine. So that urine is kind of like liquid gold. It can give us a lot of important information about what's going on in the kidney level.
So when you spun the kidney, is that kind of separating out various parts of the urine so you can look at them, or what is that doing?
So when we spin urine, it's actually just because the urine sample is so diverse between lots of people, right? We want to make sure that we just look at the cells and the crystals and any other components in the urine that's important. So when you spin something, the cells and everything get pushed to the end and kind of clumped together and concentrated. And that's what we want to look at. And that's standardized. That's how we're trained, so that this person's urine is we're comparing apples to apples. This person's urine is now comparable to that person's urine and compared to somebody else's urine, right? So because we're concentrating the findings instead of, if you look at something that's very dilute, then you might just miss it, right? Because there's only like one or two little particles that you're interested in this big sample, and we don't want to miss something. So that's why we have to spin it down into a little pellet and then look at that under the microscope.
So what did you see when you spun the urine and you looked at this kind of critical part of the urine that you're looking at for diagnostic purposes?
So I've seen thousands of urine samples, and what just stood out immediately were the number of crystals in the urine. Again, certain crystals by themselves are nonspecific, but the backstory plus the fact that there were so many of these calcium oxalate crystals, they were mostly fan-shaped, some of them were needle-shaped, is just classic poisoning by, ethylene glycol was the top of my mind as soon as I saw that, because now the four pieces together just really hones the diagnosis.
All right, so the first thing that you see is these calcium oxalate crystals. And you said that they're in multiple different kinds of shapes?
Correct.
All right, and so you mentioned one as a fan shape. Is that like a hand fan, kind of like if you're...
Exactly. It's a little fan. Sometimes there's two of them, so that we call them dumbbells because they kind of look like the dumbbells that you work out with. A lot of calcium oxalate crystals are actually kind of needle-shaped. And there's also the envelope, which is a dihydrate calcium oxalate crystal. The dumbbells or the fans are monohydrate calcium oxalate crystals.
All right. And we're starting to get into it, but why are these particular crystals so concerning for you when you look at a urine sample, and in particular when you looked at Mr. Fowler's urine sample?
Because, again, it's the combination of the sick patient who's altered, the acidosis, the osmolar gap, plus the urine crystals in the setting of kidney injury that really, I mean, honestly, in my years of training and experience as a attending nephrologist, it's a must not miss diagnosis. It's ethylene glycol poisoning. Those are the top 3 things that you're thinking about. And then maybe there's something else that the person ingested, which is kind of secondary because the treatment often overlaps, like the treatment for any of those other ingestions. The treatment of urgent hemodialysis can often be life-saving.
Okay. So you've mentioned a couple of times a couple of other things that were very concerning to you. One of them was metabolic acidosis. What is that?
So our body is exposed to acid, right? In the form of diet, in the form of our cells when they break down certain compounds, they release acid. It's a waste product. We're only supposed to have a very small amount of acid in our body, and our kidneys are very smart, and they will balance that so that you're not constantly in an acidic state. If you have acid, then the kidneys will generate more bicarb, which is an alkaline compound, and then together it's neutral. You get neutral pH in your blood. That's supposed to be normal. When somebody has acidosis, what that means is that that acid level is just rising. And especially with kidney injury, the kidney's not able to work normally. So the amount of bicarb and alkaline material it's trying to generate is low. It's not normal. So now you do have an acidic state in your blood instead of a neutral pH. And so that's why I was concerned. Something was generating all these extra acid molecules. And ethylene glycol breakdown, it's one of the first breakdown products in our body is glycolic acid, and that's the driver of this anion gap metabolic acidosis. Is a term for a specific type of acid buildup in the blood.
All right. So you just mentioned the next term I was going to ask you about, an anion gap. What is that, and why is that something that you look at when you have a concern about someone's kidney?
It's a way for physicians to be able to figure out where this acid is coming from. Is it because they're having massive diarrhea and they're losing a lot of alkaline material, and so the amount of acid to alkaline material in your body is off because of that? Or is it because of you ingested something, or because you're very sick and your blood pressure is super low and then there's acid being built up in your body and created by your cells? The anion gap is an old tool that looks at the electrolytes that are measured, because we cannot, even in our modern state, measure every single thing in our body. We can't. So we take what we measure and then we calculate what should be there, and we look at that difference and we say, well, that's not normal. Normally, there's only supposed to be a small difference between what we measure and what we calculate as what should be the right answer. Because when you measure the anion gap, the computer does it, and then when we calculate the anion gap, we do it. But basically, it's what we measure versus what's actually present in the body. And if that gap is not normal, then there's something that's driving that difference.
Was Mr. Fowler's gap normal?
No.
So it was concerning to you for kidney injury?
In the setting of kidney injury and as potentially the cause of kidney injury, yes, it was concerning.
Now, what about an osmolar gap? You mentioned that earlier. What is that?
Exactly. So that's also something the computer can measure as osmolar is a fancy way of saying what will water do in this situation. If you've got a high osmolar situation, then the water will be dragged into a very concentrated situation. And that water movement is important for us because our cells live in a water aqueous solution. So it affects our cells. So bottom line is we measure the concentration of our blood, and one way to measure that is called osmolality, and the machine does that. And then with our tools, we can actually calculate what we think the concentration should be, depending on the labs that we have available to us. And so after years and years of data, we know what a normal difference is between the measured versus our calculated osmolality. And so if there's an odd difference, right, like why is what I'm calculating not what's appearing in the machine? That means the machine is measuring something that's driving the concentration of blood to be very high, whereas we're saying these normal things that are supposed to be in your blood that we are measuring through the sodium, the chloride, the bicarbonate, the BUN, the glucose, it is not telling me that it should be this high. There's something else in the body that tells you that there's something that shouldn't be there that's in the body.
All right. So when you have an anion gap, you have an osmolar gap, you have metabolic acidosis, and you have fan-shaped and crystal-shaped calcium oxalate crystals in the urine. What's at the top of your differential diagnosis for those four things?
Ethylene glycol toxicity.
Now, in addition to those four things, are there any other signs that you look for once you suspect ethylene glycol toxicity? Are there any other things that you look for either in the tests that you're running or in the physical appearance or presentation of the patient themselves that sort of can help you confirm that diagnosis? We can start with the tests. Are there any other tests that you can run to sort of confirm that diagnosis?
Sure, you can try to measure the actual ethylene glycol level in the blood, but we know that that takes a long time for most hospitals, even the larger ones. It's usually like a send-out lab. You have to send it to a specialized lab that can do it. We can also test for some of the breakdown products. Some of the hospitals may be able to do that. But more commonly, things like lactate, which is a commonly found acid in our blood, can actually be falsely high because the machine that normally measures lactate sometimes can't differentiate oxalate with lactate. And oxalate is one of the breakdown products of ethylene glycol in our body. So there are a lot of cases where lactate is very elevated in the blood, so that also can be a hint. We have some volatile alcohol screening tests that we have to see if they've ingested methanol, but ethylene glycol is often not in that panel.
Were there any other tests that you were running specifically on Mr. Fowler, either that you ran at your hospital or that were done by Anna Jacques, that gave you, that heightened any concerns about these ethylene glycol toxicity issues, or have you covered it?
I think we covered it.
Okay.
Yes.
Great. Now, one of the things that you mentioned was the metabolites of ethylene glycol. What's the difference between these metabolites for ethylene glycol and ethylene glycol itself?
So ethylene glycol is what we call a parent compound, right? This is what it originally starts off as, and then in our body through various proteins and enzymes, it gets broken down so that eventually it gets removed from our body because it's not something that's normally in our body. So ethylene glycol itself is actually not that toxic, which is surprising. But as soon as it starts breaking down by the liver, by ADH is the first enzyme, it becomes glycolic acid, which is toxic to several organs. And then that gets further broken down in our body to oxalate. And that is what binds to the calcium in the kidney and creates these calcium oxalate crystals, which is what we see in the urine often.
So for Mr. Fowler, when you run these tests and you look at the calcium oxalate crystals, the gaps that you talked about, what are you trying to do now to help him sort of survive this condition?
So get rid of the ethylene glycol, get rid of that initial compound because then it's not going to break down into further compounds. Either that or stop the compound from breaking down. And so we have a medication called fomepizole, which blocks that first enzyme that starts breaking down ethylene glycol. So we gave that immediately. And then while that was going, I tried to get hemodialysis started. Again, that's the procedure where a machine does the job of the kidney. It takes your blood, it gets rid of any waste products that shouldn't be there, and then it gives you the cleaned blood back. Because that removes both the ethylene glycol and actually its breakdown products. So it'll be able to get rid of all those toxic metabolites as well.
And if you have a pre-existing kidney issue or kidney problem when you're exposed to ethylene glycol, what does that do to the body?
So the ethylene glycol would stay in your body. The kidneys would not be able to get rid of it effectively. So now all of that ethylene glycol is being broken down into its toxic metabolites, and that's also pretty much staying in your body longer than it normally would if the kidney function were normal.
Now, is hip and back pain a sign of of any particular thing that would be concerning to you for somebody who's complaining of kidney issues or kidney problems?
I would definitely consider it. Obviously, there are some more common problems of hip and back pain, but combine it with any urinary symptom, and I'm heightened to think that it's the kidney. It's not your muscles. It's not your bones. It's the combination of any kind of lower flank pain with urinary symptoms, because that's what the kidneys do, would make me think of kidney injury.
So urinary issues, would that include an inability to urinate?
Definitely.
Your Honor, at this time, I'd like to mark the medical records from Mount Auburn Hospital subject to any issues as the next
all right.
exhibit.
It may be marked.
Not a problem, Judge.
Cindy, thank you. That's okay.
And ma'am, you had already indicated to us that you had the option to the opportunity to take a look at the medical records from Mount Auburn before you came in here today. Is that correct?
Yes.
All right. And you, in addition to numerous other treating physicians and PAs and nurses and everybody else at Mount Auburn, did a report in connection with your work on this particular case. All right. And ma'am, I'm sorry?
What page number and bottom at?
31. I'm just going to hand you, ma'am, one page out of those medical records that we just marked as the next exhibit. Do you recognize the image at the top of that page?
Right. So this is the dumbbell shape. So you've got like the two.
Stop you for 1 sec there. So you recognize that as a photograph or an image that you placed in your report in connection with this case?
This is from my note, from my initial consultant note in the morning, and I took a photograph of what I saw in the urine in the microscope.
All right. We have, actually, it's already in evidence. I'm just going to put it up on the screen for the jury to take a look at. All right. Just gonna... All right. Now, doctor, if you could see on the screen next to you, you should be able to see that as well.
Yes.
And it's a little bit blurry, but that's because it's the way the image was created. Could you tell us what we're looking at there?
Yes. So the backdrop is urine, and it's very, very a tiny amount of backdrop urine, because again, we spin it down and we concentrate whatever's in the urine into a very standardized volume. So in the backdrop there's urine, but right in the center is this, there are two fanned out shapes that are connected, and you can also see the lines of the crystalline structure, but that's what we call a dumbbell shaped calcium oxalate crystal.
Okay. And those are particularly associated with ethylene glycol toxicity?
Only in the context of having all those other pieces together. Calcium oxalate crystals alone are actually not that specific. It's just, again, all those 5 pieces of information together now hones in the diagnosis.
Awesome. Great. Thank you. Now, you learned during the course of your treatment of Mr. Fowler that he had some cocaine in his system. Is that correct? Mm-hmm. Any of those, the osmolar gap, the anion gap, the crystals, are those concerned? Would those be associated with cocaine or cocaine use?
Not directly. So cocaine use can wreak havoc on the cardiovascular system. It can make your blood pressure go high. It can make your heart race, right? Your heart rate's going fast. And at that point, your body's trying to also respond and regulate. And so it can cause muscle injury, like the actual cocaine use itself, or blood pressure variations to the point where we get certain slightly abnormal lab values, but not this combination of like an anion gap, acidosis, and certainly not an osmolar gap. No, you would never get an osmolar gap with cocaine use.
Same with the defense, Mr. Fowler, he had a pacemaker. Any concern that the pacemaker would have sort of created any of these, a misfunction or a malfunction of the pacemaker would have created or caused any of these symptoms that you were seeing?
Theoretically, if, his blood pressure were low, but actually his blood pressure was pretty normal throughout our hospitalization. And if you look at the Anna Jacques records, it was actually pretty normal there too. So no, nothing directly about a pacemaker would make, these lab abnormalities.
All right. There's one other thing. Where's the bell? Yeah, what are the, did Mr. Fowler's presentation at Anna Jacques and then at Mount Auburn follow a particular form of ethylene glycol toxicity that you're familiar with?
Yes. So ethylene glycol toxicity usually takes kind of 3 stages. Very early on, neurologic. So almost like somebody who's drunk, they're inebriated, their central nervous system isn't, working properly. So it's very nonspecific, right? So they just act confused and not normal. But second stage, you start seeing things with their heart and lungs. So blood pressure can be high, heart rate can be abnormal, it can be very high. And then there's actual lung injury, so then patients actually have trouble breathing. And then the third stage is kidney injury or sometimes just outright failure, where you can't even make urine anymore. So that's much later on. But like I'd mentioned before, there might have been other reasons why you could have kidney injury. So it can get very messy, but usually those are the 3 classic kind of stages of ethylene glycol toxicity: the brain, the heart and lungs, and then the kidneys.
All right. Now, one of the things that you did not have the advantage of when you were treating and trying to diagnose Mr. Fowler was the result of any blood test for ethylene glycol on November 11th or November 12th, 2022, correct?
Yes.
Okay. Now, in preparation for your trial testimony here today, did you learn that blood was taken from Mr. Fowler at Anna Jacques Hospital and later tested for ethylene glycol during the course of essentially his autopsy?
Yes.
Okay.
I found that in the report, yeah.
Okay. And the combination, and you learned that his ethylene glycol levels in his blood were 52 milligrams per deciliter, is that correct?
Correct.
Now, the combination of everything that you've talked about for us today, the anion gap, the osmolar gap, the metabolic acidosis, and the calcium oxalate crystals in the urine, when you combine that with ethylene glycol, a positive result for ethylene glycol in a blood test, do you have an opinion to a reasonable degree of medical certainty what the diagnosis would be under those conditions?
Certainly. It would be ethylene glycol toxicity.
Great. Thank you. Judge, I don't have any more questions. I would like at this time to mark the Beth Israel medical records with the same.
Subject to potential redaction, yes.
Thank you.
Mr. Norkunas.
Thank you, Judge. Good afternoon, Doctor.
Afternoon.
I have no medical training. I'll tell you that before I begin on some of these questions. But you indicated there are 3 phases generally accepted within someone who does have ethylene glycol toxicity, right? And the first one would be a person has it, and they may appear to be what we normally associate with somebody who's drunk. They're losing muscle control, they might be falling down, they appear to be a little bit dizzy. They could even be, some people get nausea, right?
Mm-hmm.
With that and that. And in the context of, and then you had gone into 2 other phases, which I'll ask you about in a minute. But when a person ingests ethylene glycol, that's quickly absorbed by the water. Is that correct? within the
It
body?
is quickly absorbed into your blood, yes.
And would it be fair to say it has, the term I've seen used is a very short half-life, the ethylene glycol itself? And
So this is tough.
what that really means?
Yes. So any compound has what's called a half-life. Like how long will it last in your body? And so that's why we care about things like, oh, is the liver working? Is the kidney working? Because all of those pieces usually are involved in what takes, X amount of hours or even minutes for a certain compound to just break down in your body. Okay. So ethylene glycol, though, is tricky. If you look at the literature, if your kidney function is stone cold normal, then fine. Few hours, usually about 4 and longer and change, is the half-life of ethylene glycol, if I recall correctly. So I'm not a toxicologist, I'm a nephrologist, but my point is, what that means is that if you have, let's say, 100 units of something, right? What is the time that it will take to get rid of half of it? That's a half-life. And so, it's usually on the order of like hours for ethylene glycol, but that's if the kidney function is normal. If the kidney function is not normal, the kidneys are the ones that are getting rid of it. If they're not functioning, then your ethylene glycol level will be higher. It won't be the usual 4 to 8 hours, I think it is. It's going to be pushed further back to about 12, if not longer, in your body.
So a person consumes ethylene glycol, and you've indicated, it's like initially ethylene glycol by itself, without any metabolism within the body, would not be destructive if it didn't go into all of those other pieces, correct?
Correct.
And at some point in time, ethylene glycol, one of the side effects, bad side effects, is the calcium oxalate crystals in a person's kidney, right? I hope I'm pointing to the right spot of the kidney.
Yeah.
I'm grabbing myself. I don't even know where they are. But it's the ethylene glycol, and that is part of the metabolism process, creating the calcium oxalate crystals.
Right. So the ethylene glycol is broken down, and the first step is mostly in the liver, actually. So the enzyme that we care about, ADH, alcohol dehydrogenase, is in the liver. And so the ethylene glycol gets broken down into glycolic acid, and then ultimately broken down further into oxalate.
Now, it's a timeline type issue. You've told what happens in stage 1 before we get to stage 2. So some of that ethylene glycol now has disappeared from your system and become oxalate crystals, right? Calcium oxalate crystals.
Mm-hmm.
Would there still be, the process then is the crystals themselves don't go over into those other 2 acids you mentioned. They don't become part of that, they don't further metabolize into the acids, right? So it's almost like there's a divide someplace in my body. Some crystals, some of the ethylene glycol is going to create crystals, and some other aspects, as it metabolizes, are going to become the acids. How does the ethylene glycol that's changing not all become crystals in my kidney?
Because the body's not perfect. So this is why we talk about half-lives, right? We have a certain amount, and then in a certain amount of time, we have half that disappears, right? So, and then we have that same amount of time, and another half disappears. It's first-order kinetics. So, it's not like this beautiful, straight line. Some of it's going to be broken down into, glycolic acid. Some of the ethylene glycol is still in our body later to be broken down into glycolic acid. And then some of that glycolic acid is broken down into oxalate and deposited potentially in the kidney. But it's just not a beautiful, clear-cut breakdown. The body's kind of messy. So we have these things where we say the half-life is a huge range of hours. It's not just a specific number. And then you add on kidney injury, and the range becomes even wider. So it's just hard to predict exactly how it's going to be broken down. It's a little messy.
Okay. And in the context of so there's 3 things going on at one time. There's ethylene glycol still floating through the bloodstream.
Mm-hmm.
There's some crystals being created.
Mm-hmm.
And then there's some metabolism taking place in terms of the acids. And that's all simultaneous.
Yep.
And so, and at some point in time, though, all of the ethylene, if you were doing a blood test, when you get to stage 2 or 3, you've talked about, you wouldn't find any actual ethylene glycol anymore in the system, correct? It would now have either metabolized or gone to crystals? Time goes on, there's a timeline, right?
Yes.
And at some point in the timeline, the person could still have the crystals and still have, and the acids which are causing all the further damage, but no longer would the blood test show ethylene glycol itself.
It's possible, yes.
But do you think it could also be the other way? You could always test for it some period of time.
Yes.
At some point in time, did Anna Jacques, did Mount Auburn, though, send out any blood to be tested? Let me strike that question. Do you use Quest in the hospital for your blood tests?
Not always.
And let me show you one page of the records, page 25. I may approach you.
Yes, you may.
Oh, okay. Yeah. 11, 13. Okay. Right. Okay.
Doctor, I'd ask you to look at that page. Does that indicate that that's a record from the Quest lab at Mount Auburn, blood lab?
Yes, so it's dated, the collection is actually 11/12/22, 13/42, so he is
Does it say
physically
that
still at Mount
ethylene
Auburn.
glycol, none detected?
Yes,
And that was on 11/11, correct?
11/12.
11/12, right.
So he's at Mount Auburn. This is a Mount Auburn sample.
So that was after he was transferred to your hospital. And then would that have been the initial test itself, or that would have been a subsequent test?
Subsequent, because he arrived, I might have to go through my notes, but he arrived somewhere late 11/11 to early 11/12, after midnight on 11/12 is I think when he actually arrived to Mount Auburn. And then we started collecting our own labs. So this being collected at 1:42 in the afternoon means he's been at Mount Auburn for a little bit on this day.
So that would have been 1:22, that would have been 12 o'clock, 1 o'clock on the 12th.
Correct.
If I can reclaim that.
Yeah.
In terms of the stages, then, I think you've talked about that. In stage 2, you could have rapid breathing. You could have a very fast heart rate, correct? And if a person had a pacemaker, the pacemaker would be trying to deal with the fast heart rate.
Mm-hmm. Although normally it prevents low heart rates. Like if your heart rate's really low, the pacemaker will make your heart pump at a certain rate.
Now, and then in this particular case, then usually stage 3 with that type of ingestion is renal failure, which causes your death, right?
It's usually cardiovascular collapse, actually.
He died of a stroke, right?
It'd be part of cardiovascular system, yes. But it's really interesting because he came into Anna Jacques with a kidney injury. So this makes everything very murky, right? So if you already have your kidneys injured, again, it could have been from something else, and then ethylene glycol is introduced. Now things get really messy because like that half-life of ethylene glycol is now just expanded. And those clean, stages don't really exist. And the timeline for those stages are much less clear.
Okay. So the aspect of this, though, where normally, or not normally, but in many cases, the person who has ingested the ethylene glycol, the cause of death is the renal failure, right? If that is from your experience as a doctor. My kidneys don't work, what happens to me?
So actually, people who have kidney disease, they generally die from their heart. The heart cannot tolerate the environment that has been created because the kidneys are failing. Acid levels rising, blood pressure is abnormal, electrolytes are so abnormal, the heart is no longer able to pump normally because we use the calcium, we use potassium to be able to regulate our heart signaling and pumping. And so when the calcium and the potassium are not normal because the kidneys have failed, pumping. And so when the calcium and the potassium are not normal because the kidneys have failed, that's when people get into big trouble and they have cardiac events. So I can speak to end-stage kidney disease, but ethylene glycol toxicity, usually kidney failure is blamed as a big part of why the patient died. But again, in the setting of kidney failure, it's usually the final thing that does it is usually the heart gives out, right? Because it's almost like semantics, right? Like if the kidneys have created an environment that is so bad, your heart will stop because of that. So are you going to blame the heart? Are you going to blame the kidneys? I would say both.
At some point in time, though, on the 12th of November, your hospital, it might have been under your direction, you gave him dialysis and cured him of any ethylene glycol anymore, correct?
Yes, exactly. We removed ethylene glycol and its metabolites. However, many studies have shown that you can't predict with 100% certainty how much you're going to remove. So after the dialysis is done, then we continue to do testing like the osmolar gap, like the anion gap, to see if there's indication for further dialysis. Because like at most places, the ethylene glycol results just don't come back fast enough for us to be able to say, hey, we cleared the ethylene glycol, let's stop the dialysis. We have to, again, go by those very, very suggestive blood tests that we had at the very beginning of his presentation as well, the osmolar gap, the anion gap, acidosis.
After the dialysis was done and that process indicated that the ethanol glycol was on, did you do those other 3 tests again? And did that show you that those were back to normal for Mr. Fowler?
So they were back to normal, but he was transferred to BI at that point. He became so unstable, he had a seizure, that the Beth Israel Hospital is a larger tertiary hospital. They have a neuro ICU. They've got they've got ECMO. They've got more things that could have been done. And so we had transferred him. And I know, because I reviewed the chart, that at that point it had resolved. The anion gap had resolved. The osmolar gap had resolved. And actually, I think you're right. Right before we transferred him, I think we also did measure at Mount Auburn as well, but BI confirmed it, like they're both resolved. And he didn't need any more dialysis immediately when he was transferred.
Mr. Camelio had asked you, you had looked at the results that came back from the lab that tested the Anna Jacques blood, and they came back, I think it's 52, is it
milligrams per deciliter.
Per deciliter.
Mm-hmm.
That, would you be able to transform that into grams? Is that equal to approximately 26 grams, the equivalent of it, the 52 per deciliter?
Oh, I didn't do the math. You just would need the molecular weight, though. Yeah, so you would divide that by the molecular weight of ethylene glycol.
I'm not being good at math. I can't make that. You can make the equation from that system to the dry system. That's a liquid system, and then you're going into a dry system of grams. Is it approximately somewhere around 26 grams might be a good estimate?
Yes.
Okay. I can have a moment, doctor, and judge. I have a moment.
Yes, you may.
Within the context of treating ethylene glycol ingestion on individuals, is there a timeline within the hospitals that you can get to a person within so many hours you can rectify the damage that the ethylene glycol may be doing? You were talking about the 3 stages. So if you get in stage 1 in 3 or 4 or 5 hours, might I be saved?
So there isn't very good data on this because we don't randomize people to be exposed to something that toxic. So we have a lot of observations. What that means is, somebody comes into the hospital, they report that they took X, Y, and Z a certain amount of hours ago, so we have to take their word for it. We can't even necessarily be sure that that's true. So we've got all these reports, but I can't say with any certainty that, he would definitely have been saved if he were treated, within an X amount of hours. What we do know from all of these reports is that generally the people who are treated earlier tend to do better. People who have delayed treatment tend to do a lot worse and not be able to survive. But what that exact hour cutoff is, nobody could tell you that.
There had been an old, fisherman's type tale. If you knew someone had that, you give him a fifth of Johnny Walker Red right away, and that may save them.
I smile, but that's actually true. So remember, the breakdown of ethylene glycol in the liver to glycolic acid is done by ADH. It's an enzyme. We only have a certain amount of it at a given time. ADH also breaks down ethanol, which is alcohol, the alcohol that we're talking about when we talk about drinking alcohol. So if you give ethanol, then it will actually trick the enzyme into working and breaking that down, and it won't break down the ethylene glycol as effectively. So yes, that was an old treatment that we had for ethylene glycol and even like methanol toxicity, because you would divert and you would prevent the breakdown of ethylene glycol.
Thank you, Doctor. I don't have anything further else, Judge. Thank you, Doctor.
Mr. Camelio, anything further?
Just one thing I wanted to clear up, Doctor. You said that a lot of the numbers, the osmolar gap, the anion gap, they went back to normal after dialysis. Mm-hmm. Now, dialysis can help to clear the ethylene glycol and the metabolites from the system, but the dialysis does not repair the damage that they have already done to the liver, to the heart, to the brain, to anything else. Correct?
No. Nope, not even the kidney. They do not actually help repair the kidney. They just literally are doing what the kidney should or would do if it weren't severely injured.
So if the injury is to the heart, the brain, the kidney, the liver are already too great, then it doesn't matter that you've already gotten the ethylene glycol out of the body.
Yeah.
Thank you. Nothing further.
Any follow-up on that, Mr. Norkunas?
No further questions, Judge.
Thank you very much, Doctor. You may step down.
Thank you.
William Eaton.
Judge, could I have a moment with the prosecutor?
Yes.
You can still come forward.
Right. Just gonna ask you to stand behind this blue line and face the clerk.
Sir, would you raise your right hand for me, please? Do you solemnly